So for fetal growth restriction, this has been a more recent discovery because in the beginning of the 20th century, most babies who were born small were thought to be premature. And then it wasn't until the mid 20th century that the World Health Organization started classifying babies who were born at less than 2,500 grams as being low birth weight, regardless of their gestational age. And then it wasn't until the 1960s that there were detailed graphs of, of birth weight as a function of gestational age that were identified, and then they could associate that birth weight with adverse outcomes depending on what gestational age of delivery is present. So there are different definitions of low birth weight. So you have a low birth weight because a baby was born prematurely. You have low birth weight because a baby is preterm and growth restricted. And you have low birth weight because a baby is born at term, but is also growth restricted. So the definition of growth restriction is complicated because there's not a uniform definition of what we follow. So here in the United States, we use a estimated weight of less than a 10th percentile, or the abdominal circumference, or خصر تبع البيبي, يعني less than the 10th percentile as well. The use of the 10th percentile for fetal weight increases the sensitivity of the diagnosis of growth restriction, and ultimately you have less stillbirths. But the trade-off is that it decreases the positive predictive value, and so you might have an increase in babies being born early unnecessarily because of a false diagnosis of growth restriction. The use of the 3rd percentile increases the likelihood that you are truly picking up a baby who is compromised and growth restricted, and then therefore decreases the risk of unnecessary preterm birth. However, it can miss babies who are growth restricted above the 3rd percentile, and therefore you increase the risk of stillbirths or babies dying inside the womb before birth, because they're not being monitored adequately. The other problem with the definition of growth restriction is that there's not a distinction or a difference between babies who are truly growth restricted versus babies who are small but normally small according to their genetic profile. So if you have families that are relatively shorter in height, then they will produce smaller babies, and that's normal for them. But the definition of growth restriction does not distinguish between the two of them very easily. So there have been efforts to have alternative definitions of growth restriction, and these are all the efforts I have listed, but none of these efforts have actually been shown to improve the outcome for the baby during the pregnancy or after birth. So we still here, at least in the United States, we use the cutoff of the 10th percentile for fetal growth restriction. So how common is fetal growth restriction? It depends on the population that you're taking care of and where in the world you're practicing. And it also depends on the standard growth chart that you're using in the cutoff used for diagnosis. So in the developed world, the incidence of growth restriction is up to 10%. In the developing world, it's up to 30%. And it's also important to understand that babies who are born with low birth weight, about a third of them will ultimately have fetal growth restriction as well. So it's not just prematurity. There's those who could be premature and have growth restriction, or those who are term and are low birth weight and have growth restriction. The reason why we care so much about fetal growth restriction is because the smaller that a baby is, the more likely that there's going to be a problem with either complications during pregnancy or after birth, or risk of death or mortality. So the risk starts to increase somewhat at below the 10th percentile, and then it starts to increase sharply below the 5th and especially below the 3rd percentile. So fetal growth restriction is the second most common cause for infant morbidity and mortality, second to prematurity. Males who are growth restricted actually have a higher risk of complication than females with growth restriction. And the risk of death is increased if prematurity is increased on fetal growth restriction. So you have both prematurity and fetal growth restriction, the risk of mortality is increased further than if just prematurity. And also those fetuses who are growth restricted have a higher risk of having complications during labor and in turn needing a C-section. So you'll see that as fetuses measure smaller, there's a higher risk of death in utero or stillbirth. So at the 10th percentile, the risk of stillbirth is 1.5%, which is twice as high as the normal or background rate of stillbirth. And then that risk increases to 2.5% when less than the 5th percentile. And then the worst outcomes are noted who are in those who are less than the 3rd percentile, or those who have Doppler abnormalities. So there are both short and long-term complications of fetal growth restriction. Most of the short-term complications are metabolic in nature, but they also include temperature control problems, impaired immune function, respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. So all of these risks are increased in babies who are born with fetal growth restriction. Long-term complications, so if you have a growth restricted child that is born, they are automatically at increased risk of conditions that can happen later in life. So that are increased risk of high blood pressure, of problems with the heart and lungs, and an increased risk of type 2 diabetes. There's also increased risk of developmental delays and lower IQ scores, as well as risk of cerebral palsy. So when we think about a patient that has fetal growth restriction, we can split them into 3 different categories. So there can be growth restriction because of problems that are because of the fetus, growth restriction because of placental factors, and growth restriction because of problems that mom has, so medical conditions that mom has that increases the risk of growth restriction. So the fetal factors include genetic abnormalities with the anatomy of the fetus, twins, triplets, or higher order multiple gestations, or if there's an infection. So the contribution of genetics, so up to 50% of our growth potential is determined by our genetic profile. So once again, kind of average height in a family is very important when considering whether or not a baby is truly growth restricted versus that being a normal constitution for that fetus. There is a higher contribution of maternal genes towards fetal growth than paternal genes. So the mom makes more of a difference in how the baby grows than the father. And there also tends to be a genetic link to fetal growth restriction. So if there's a family history of individuals who give birth to smaller babies, then there's an increased risk in subsequent generations of those families having growth restricted fetuses. Also, chromosome abnormalities account for up to 20% of growth-restricted fetuses. So from the genetic standpoint, chromosome abnormalities, the most common being trisomy 18, 13, Turner syndrome, and triploidy. And there are other more rare types of chromosome abnormalities that can contribute to fetal growth restriction. So it's very important that if you have a pregnancy that's affected by growth restriction, that you offer them genetic testing, including amniocentesis, to see if there is an underlying genetic condition. So congenital anomalies or abnormalities in the anatomy of the fetus accounts for about 1% to 2% of growth restricted cases. The most common being abdominal wall defects like omphalocele and gastroschisis, congenital diaphragmatic hernia, skeletal dysplasias, and heart conditions. So fetuses who have heart abnormalities are actually more likely to have placental function problems, and so these babies usually don't grow as well as their normal counterparts. So with multiple gestations are also prone to growth restriction. So the more fetuses you add, the higher the likelihood of there being a growth problem. And so this is most likely a supply and demand issue. And also the fact that pregnancy complications are much more common in those with multiples. So preeclampsia, for example, is more common in those with multiples, and preeclampsia has a higher association with growth restriction. And multiple gestations also have a higher risk of placental and umbilical cord abnormalities. And the more fetuses you add, the higher the risk of there being growth restriction. So with twins, the risk of growth restriction is up to 25%. And when you have triplets or quads, that risk is up to 60%. So this is a picture of this is a twin placenta. So you can see here's one umbilical cord inserting normally into the placenta. And then here's another umbilical cord that is an example of a velamentous cord insertion. So you see the cord actually inserts into the membrane and not into the placenta. So it inserts into the membrane, and then the blood vessels make their way across the membrane and into the placenta. And so this is, an obvious case where fetal growth restriction might be more likely. So infection is another culprit for fetal growth restriction. So accounts for up to 10% of cases of FGR. In the developed world, the cytomegalovirus or CMV is the most common culprit for growth restriction. Malaria, otherwise, is the most common infectious agent worldwide. Placental factors, so most common is ischemic placental disease or placental insufficiency. There also can be abnormalities in the blood vessel configuration of the placenta or umbilical cord, where instead of having a 3-vessel umbilical cord, you can have a 2-vessel umbilical cord. You can also have twin-to-twin transfusion syndrome, which is a very common cause of growth restriction when you have monochorionic twins. There also can be some lesions or masses that grow within the placenta. And you can also have genetic changes within the placenta itself that are also not present in the fetus that can increase the risk of fetal growth restriction. Okay, so histologic abnormalities of the placenta. You can have the most common reason that you might have growth restriction from histologic abnormalities usually is abruption of the placenta. But the remainder of these also can be present. So you can have chronic infections of the placenta, inflammatory lesions, which is often secondary to things like lupus or other autoimmune type conditions. You can have infarction of the placenta. in rare conditions such as thrombosis and something called massive perivillous fibrin deposition. And these pictures of the placenta are examples of the massive fibrin that can be deposited within the placenta. You can see where the placenta is normally kind of like a beefy red and purple, mixture of colors. Here you can see there's a lot of yellow within the placenta, and that's fibrin deposits within the placenta. And if you section the same placenta, you can see that you can see all of this fibrin deposition within the placenta. And usually patients that have this present with recurrent pregnancies that have severe fetal growth restriction and have unpredicted losses or deaths of the fetus in the late second to early third trimesters. So here's confined placental mosaicism, which is where a chromosome abnormality can be present in the placenta itself, but not in the fetus. It's predicted that up to 10% of placentas that in growth restricted pregnancies can have abnormalities in chromosome number that are confined to the placenta and not the fetus. And the severity of the growth restriction depends on the chromosomes that are involved and the number of cells that are affected by that chromosome condition. So maternal factors that are involved with fetal growth restriction are many. The most common would be diseases resulting in placental insufficiency. And those are things like high blood pressure, diabetes, poorly controlled asthma, and others. But there are many other conditions that can lead to fetal growth restriction with a notable contribution to assisted reproductive technology such as IVF, as there is a significant association between those two entities. So it's important, as we're talking about fetal growth restriction, it's important to speak in terms of what normal fetal growth looks like. And fetal growth occurs in 3 phases throughout the pregnancy. In the first 16 weeks, you have cellular hyperplasia. And then between 16 and 32 weeks, you have a combination of cellular hyperplasia and cellular hypertrophy. And between 32 weeks in turn, you have cellular hypertrophy as the sole contributor of fetal growth. And it's also helpful to know what the normal rate of fetal growth is throughout pregnancy, so that you're able to determine if fetal growth is appropriate. So it tends to increase linearly throughout the pregnancy, with a slower rate of growth in the late first to early second trimester, and a significantly increased rate of growth as you're getting beyond 32 weeks. So there are 2 different categories of fetal growth restriction, where you have symmetric growth restriction, which often presents early in the pregnancy, especially below 24 weeks gestation. And this makes up to 30% of growth restricted babies. And this is primarily a problem with early impairment of cellular hyperplasia. And because of that, all fetal organs are affected with a proportional decrease in size. And then you have asymmetric fetal growth restriction, which is typically growth restriction that happens later in pregnancy, usually in the 3rd trimester, where you have the abdominal circumference lags behind the rest of the baby, especially lags behind the head circumference. The reason why this happens is because asymmetric fetal growth restriction is usually caused by placental insufficiency. And when the fetus is receiving less nutrients and oxygen from the placenta, the fetus selectively redistributes blood flow to vital organs like the brain, the heart, the placenta, and diverts blood away from abdominal organs. as well as the lungs, skin, and the kidneys. And so that because of that, you have less growth in the abdomen and more growth in places like the head. So when you're diagnosing fetal growth restriction, it is very important that you have an accurate assessment of gestational age. So ideally, a patient's coming in the first trimester, and they have an ultrasound, and that agrees with their last menstrual period, and under those circumstances that patient is well dated, that their due date is as accurate as it can be. If you don't have that, then it becomes more difficult to diagnose fetal growth restriction, you have to use ultrasound findings like femur length or cerebellar diameter to kind of help you with understanding what exactly is the most accurate assessment of gestational age for that fetus. The other way that growth restriction is often found is in the office if you're measuring the fundal height. So if you're using a tape measure from the pubic symphysis to the height to the top of the fundus, there is correlation between what the measurement is and what the gestational age of the fetus is. So if you have a discrepancy of more than 3 centimeters, then that patient is at risk of having fetal growth restriction and should have an ultrasound performed. So ultrasound is really the most accurate way of identifying a growth restricted fetus. And once you have the diagnosis, it's important that you look at the amniotic fluid assessment, because especially in those who have placental insufficiency, there's a higher likelihood that they have low fluid. And the other thing that's important to do is get Doppler studies. So Doppler of the umbilical cord, Doppler of the umbilical artery specifically, which is a reflection of how placenta is functioning. And we'll talk about that here shortly. The lagging abdominal circumference, this is probably, if you were to choose one measurement that is the most highly correlated with fetal growth restriction, it's the abdominal circumference. It's the most sensitive indicator of growth restriction. So typically, if you have a baby that you think might be growth restricted, but their abdominal circumference is normal, then it's likely not true growth restriction. And the other important thing is that the length of time in between ultrasounds is important. If you try to follow growth on a weekly basis, ultrasound is not good, is not sensitive enough to accurately follow growth of the fetus. It has to be at least 2-week intervals, and it's better if it's 3 to 4 week intervals between ultrasounds, so that you can get the most accurate sense of how the baby is growing. Once you identify a growth restricted baby, it's important that you look at the fetus from head to toe to make sure that you don't see any anatomic abnormalities. So you do a detailed fetal anatomic survey, because when you have growth restriction, there's up to a 10% risk of finding a problem with the brain, the heart, kidneys, or some other structure. We also offer amniocentesis to pregnancies with growth restriction, especially if there is an abnormality in the anatomy or if there's high fluid around the baby. Because when you have those, then that increases the likelihood of there being a genetic or chromosome condition. If you do an amniocentesis, you can also check for infections. You can also check the maternal blood for antibodies against certain infections. So here in the US, we often offer CMV antibody testing, but depending on what infections are common, in your area of practice, if those are associated with growth restriction, especially things like toxoplasmosis, for example, those are important infections to look for, depending on kind of the region that you're practicing. So once you diagnose growth restriction, it's important that the pregnancy is monitored, where we tell the mom to pay attention to how much the baby is moving and to present to the hospital if they feel that there is decreased movement. We also use biophysical profiles, non-stress tests. Usually it's a twice weekly monitoring strategy where they have ultrasound one day and a non-stress test the other day. We follow growth ultrasounds, again, every 2 to 4 weeks. We use Doppler and steroids as needed if we feel that there's an increased risk of delivering early. Skip that. So again, serial growth ultrasound typically performed at 2 to 4 week intervals. If the baby continues to measure small and there's poor growth in between ultrasounds, that strengthens the diagnosis of growth restriction. But if there's a normal growth velocity, then that typically is indicative more of a constitutionally small fetus, which is a fetus that is small, but is small because that's their normal growth potential. So Doppler ultrasound is the most useful tool for monitoring fetuses with growth restriction. And it's the most effective when the cause of fetal growth restriction is placental insufficiency. And Doppler studies are validated to reduce the risk of stillbirth. And so it's probably the most powerful tool that we use to reduce the risk of the fetus dying before birth. And it also decreases unnecessary preterm birth. So when you have a small baby, we use the Doppler studies to help us determine the timing of delivery. I mean, as long as they're normal, we're usually able to get to term. And there have been multiple studies that have been done that show how useful Dopplers are, Dopplers particularly of the umbilical artery. And that reduces the risk of unnecessary prematurity. So this is a schematic of what the histology looks like in the placental villi. And so this is the interface between the uterus and the placenta. And the umbilical artery Doppler studies are based on the premise that these villi units should be working properly and are patent. But as you have progressively worsening placental insufficiency, these units become obliterated. So they become diseased, and blood flow between mom and baby becomes impaired. And in turn, you have increased resistance to blood flow. And then you can see that increased resistance in the umbilical artery Doppler studies. So these are the different Doppler vessels that we interrogate. So we look at umbilical artery, middle cerebral artery, and ductus venosus, but umbilical artery is the one that is most widely accepted. So this is a normal third trimester umbilical artery Doppler. So again, so in the umbilical artery, you have systole, which is this peak, and you have diastole, which is this valley. And it's important that, and this is the baseline that we're using to see the amount of flow through the umbilical artery. So anything above this baseline is forward flow. Anything below the baseline is reverse flow. And so we want to make sure that we see adequate flow throughout diastole. And that is a normal umbilical artery Doppler study. So here you have decreased flow in diastole compared to here. So if you see there's a difference in what diastolic blood flow looks like here versus here. So when you have lower diastolic flow, that means that there's more resistance in blood flow between the fetus and the placenta. And that's because these villi are becoming more diseased and are becoming blocked or clogged. And so there's less ability for the fetus to send blood back to the placenta to be oxygenated and come back to the fetus. So you're seeing that that's happening in this in this example here. The next example is when you have absent flow in diastole. So you see these big gaps in flow in between beats. That's because there's so much resistance that when the fetal heart cycle is in diastole, blood temporarily stops flowing from the fetus to the placenta. And so these babies are more in trouble and at higher risk of stillbirth and need to be monitored more closely. And then when you see absent flow, it typically means that there is a shorter duration of time between when you identify that and when you need to deliver, because the fetus becomes more compromised. The worst of the blood flow studies to the umbilical cord, the worst of the Dopplers are reversed and diastolic flow. So here, the resistance becomes so high between the fetus and the placenta that the placental resistance exceeds the fetal resistance. So when the fetus is in diastole, blood flow is flowing backwards from the placenta back to the fetal heart. And eventually that could lead to fetal heart failure and eventual stillbirth. So this is the most concerning finding that we can see in the umbilical artery. There are other blood flow studies that we look at, but these are not recommended to be followed at least in our US based literature. So I'm not going to spend time reviewing the middle cerebral artery and the ductus venosus. Okay, so whenever you have placental insufficiency, there does tend to be a progression of findings between when you first diagnose growth restriction to when baby is at highest risk of stillbirth. So these are end stage changes. So you have growth restriction. The first thing that happens is that you have decrease in umbilical venous blood volume. And then you have the baby redistributes blood flow from the liver to the heart. Then you have lagging abdominal circumference growth. Then you have increased resistance in the umbilical artery. And then that increased resistance later results in absent or reverse flow in the umbilical artery. And then you start having changes in fetal monitoring, such as the biophysical profile or the non-stress test. And then you start having recurrent decelerations, late decelerations in the fetal heart rate monitor. And when this is where you pick up babies right before a stillbirth occurs. Ideally, delivery happens up here before you start seeing changes in this category. So like I said earlier, the frequency of testing of fetal well-being is based on the severity of growth restriction. Most of the time, we recommend doing twice a week testing, and that helps to ensure fetal well-being throughout the week. And in many practices, they use both ultrasound and non-stress tests. Ultrasound is important because it does the Doppler studies, and then you also do non-stress tests. So if you do like a Monday, Thursday, or a Tuesday, Friday type of testing strategy, then that's usually good spacing in between testing to ensure fetal well-being. And if you have any concerns about the test, then you can admit the mom to the hospital, give steroids, especially if they're less than 34 weeks. And deliver based on how the baby is looking in the hospital. So timing of delivery, it really depends on how severe the condition is. And it also depends on what your NICU capacity is. So here in the US, we recommend delivery at 37 weeks. in pregnancies with fetal growth restriction, and if they have normal umbilical artery Doppler studies. Sorry, if they have abnormal Doppler studies, or if the baby is measuring less than the third percentile, then we deliver at 37 weeks. Okay. If the blood flow studies are normal, if the Doppler studies are normal, and the baby is between the third and 10th percentile, we recommend delivery between 38 and 39 weeks. And then we have different recommendations depending on what the other blood flow studies look like. But again, it's important that you understand what your NICU capability is, what gestational age that you start offering intervention after baby's born. And that really is what you should use in your practice to help guide you. So it's always important to consult with your NICU to determine what is the best cutoff for when life-saving interventions can be offered after baby's born. So again, here in the US, we recommend steroids if delivery is anticipated at less than 34 weeks gestation. And we consider it between 34 and 36 weeks and 6 days in those who haven't had steroids before and who don't have any other reasons that they can't receive steroids. So if they have diabetes, for example, and they're after 34 weeks, we do not recommend giving steroids because that will worsen their blood sugars and is not associated with better outcomes from the baby's perspective. So we know that during labor, those babies who are growth restricted, especially those who have abnormal Doppler studies, are at higher risk of having fetal heart rate abnormalities, and in turn have a higher risk of needing C-section and ultimately having more complications after baby is born, like having acidosis and having a higher rate of NICU admissions. And it's also important to know that once a mom has had growth restriction, once a mom has given birth to a growth restricted baby, there is an increased risk that it can happen in future pregnancies. So there's a 20% risk of recurrence in the future. And if it's happened twice before, then there's a 44% risk of recurrence in the future. So anybody who has had a prior growth restricted baby should have ultrasounds performed regularly throughout their pregnancy, about every 4 to 6 weeks, to make sure that future pregnancies are not affected by fetal growth restriction. So, in summary, if you do diagnose growth restriction, it's important to do a detailed anatomy scan to make sure there are not any associated anatomic abnormalities. It's important to think about the contribution to genetics. So if aneuploidy screening is done or amniocentesis is done, depending on the clinical factors. It's always important to think about infection and what common infections are in the region that might be associated with growth restriction. Anybody who has growth restriction, it's important that they're followed by ultrasound Doppler studies at the very least. And that helps you to determine need for hospitalization, timing of delivery, and timing and need of steroid administration. And it's important to know as well that those who have growth restriction are at higher risk of having problems during labor, especially risk of abnormal fetal heart tracings and increased risk of cesarean delivery, and that fetal growth restriction can recur in future pregnancies. Thank you very much. يعني شكرا كثير لكم. الله يجزيكم الخير.